Good afternoon, everyone. Thank you for joining us. I'd like to welcome you to our fourth Lung Learning Lab of 2025. I'm Megan Spearoff with the Inhale Coordinating Center. I've been filling in for Brenna while she's out on leave. Today we're joined by Dr. Meilon Han. She'll be presenting on the burden of COPD. A couple of housekeeping items before we begin. To record your attendance for today's event and to receive your VBR credit, I'll be emailing out a post-event survey to all attendees. It's important that you enter your name, practice, and PO correctly to record your attendance. If you need any help with that afterwards, please feel free to email us. I did want to give an update that due to some last minute changes, we are not able to offer CME for today's event. I do apologize for this change. One reminder too is that we are recording this session and it will be posted to our Inhale Learning platform for on-demand viewing. So without further ado, I will introduce Dr. Han. Dr. Han is I have a long bio for her, but she said just hit the highlights. So she um, is the chief of the Division of Pulmonary and uh, Critical Care at the University of Michigan Health, and she also serves as a member on the Global Obstructive Lung Disease Scientific Committee, which is charged with developing an internationally recognized consensus statement on COPD diagnosis and management. So, Dr. Han, I will let you take it away.
Well, hi everyone. Thanks for joining on your lunch hour. I'll try to make this hopefully interesting and quick. Given the audience, well, this kind of goes through a little bit of the history and challenges with COPD. I'll try to also weave in some current management strategies where I can as well. Um, this is kind of a rapidly evolving field, and there's actually two new medications that have been approved for COPD in the last year. And if I can, I will touch on those as well in my relevant disclosures. Um, so when we think about the history of COPD, and a version of this talk I actually first gave at the ATS President Symposium a few years ago, which was kind of celebrating the kind of long history of the ATS as well as the NHLBI partnership um, for studying lung disease. It's interesting because the term COPD is actually a fairly modern term. And the first kind of recognition that something could go wrong in the lungs that was at least somewhat related to COPD historically was really kind of fluid in the lungs and chronic bronchitis. And this was noted by Laennec back in 1819. And then if you kind of look at how the idea of COPD evolved over time, sort of the first kind of thoughts about it with this idea of chronic bronchitis and emphysema were first introduced in the late 50s. And ultimately, the term COPD actually itself wasn't introduced until the mid 60s. And then the spirometric definition that we have today based on spirometry wasn't introduced until the late 80s. So I think this is when you think about some of the challenges with getting pulmonary function testing, and that's a little bit of another story. We're a little bit kind of late to the game, which has carry forward consequences in that we've still got many, many patients with COPD, unfortunately, who are undiagnosed. And so that's kind of some of what I wanted to talk about today. So when we kind of think about early disease, there's actually two separate problems. One, there's a bunch of undiagnosed patients that really probably should be treated. And the estimates are that in the US, we have about 15 million people who are diagnosed, of which, by the way, only about a third have had appropriate diagnoses with spirometry. But then the other half, there's probably another roughly 15 million that are out there undiagnosed. And so that's kind of challenge number one. And then challenge number two, which we're still trying to get our heads around, is that there's a lot of patients who probably don't fit our current diagnostic criteria. but may need some kind of treatment. But that's still sort of being investigated. But I'm going to talk about both concepts today. Ultimately, the reason why all this matters is if we want to try to figure out how to alter the course of disease, we really need to catch patients early enough to do so, um, and to be able to test disease modifying therapies. And right now, we're kind of behind the eight ball. We detect people late, so it's hard to show that you can intervene. Excuse me, I'm going to sneeze here. Um, sorry. Um,
Bless you.
oh goodness, it's always three. Okay. Um, it's kind of like I sort of liken it to like let's say you've got a plot of land and you're trying to prevent soil erosion. But if you get there after most of the soil is eroded, you're not going to be able to do nearly as much. And unfortunately, a lot of patients kind of get picked up late and they've already got lost a lot of lung function, and then it makes it much harder to have as much impact for that patient. So I'm going to talk about the undiagnosed patients first. There are a lot of barriers to diagnosis of COPD in primary care, and I spearheaded this commission on COPD that was published in Lancet Respiratory Medicine back in 2016. But it's kind of a twofold problem. On the patient side, they tend to brush off symptoms. There tends to be poor awareness of COPD or even the appropriate diagnostic testing. And in primary care, there's a lot of time limitations. And, a lot of times you only really have the time to address one thing. We may not have spirometry readily available. And also, patients may not be forthcoming with respiratory symptoms specifically. You kind of sometimes have to probe about activity limitations and things like that. So there are a lot of challenges around the diagnosis. And what that's led to over time, though, is something I like to call therapeutic nihilism, which is, U.S. Preventive Services Task Force, as I'm going to mention the next slide, kind of keeps saying, oh, you don't need to do population-based screening because it doesn't matter. And then it just kind of becomes a self-fulfilling prophecy. One of the challenges, though, around this is that it's not so much that there's negative evidence that screening for COPD makes a difference. It's just lack of evidence. And in fact, actually, though, just in the last year, there was a paper published in the New England Journal of Medicine headed by Sean Aaron out of Canada, where he actually was able to show that when they did population-based screening, brought people in with either asthma or COPD, got them diagnosed and appropriately treated, they were able to show a reduction in healthcare utilization. So in the meantime, the U.S. Preventive Services Task Force kind of calls for additional research, but most groups, kind of like GOLD, for instance, really kind of are big proponents of case finding. So it's kind of like targeted screening, essentially. So this is sort of just summarizing what I just told you. Part of the challenges is that many patients self-restrict activity to minimize symptoms. And so it's not so much that they're asymptomatic, but you have to probe to kind of get at those symptoms. And really the recommendation's been around more lack of evidence as opposed to negative evidence, but we're starting to slowly build that. So there's this paper that was just published in the New England Journal of Medicine, and then I have a little bit of additional data I'm going to show you as well. But when we think about sort of the overall burden of COPD and who has it and who are these diagnosed people, some of the best data, this is a little bit old now, comes from David Menino, and this is CDC collected data from NHANES, which kind of went block by block and did a systematic screening methodology to try to find people who, they brought people in, asked them symptoms, prior diagnoses, and then did PFTs. And so what they found was, in blue, it's the people who had actually been told that they had chronic lung disease with either chronic bronchitis or emphysema, but in red was who actually did when you did spirometry. And so as you can see, there's definitely some people who are younger, but that the number of undiagnosed people really goes up with age, which is not surprising because we know damage accumulates over time. But just because these people are undiagnosed does not mean that they don't have disease that matters. So this is data that I think came from CanCold, which is a population-based cohort in Canada. And they just compared exacerbation events among those who were diagnosed and not diagnosed. And while the events were a little fewer in the undiagnosed, they still had events that led to symptoms, that led to treatment, in some cases still led to hospitalization. So just because someone goes undiagnosed doesn't mean they don't have clinically significant COPD. We also know that mortality is higher for patients, and this is um, uh, uh, back to the NHANES data again. But for those who have undiagnosed obstructive lung disease, it's pretty similar in terms of survival probability compared to those with diagnosed, and much worse than those who do not have any form of obstructive lung disease. So some of the things that we've been doing here at the University of Michigan to try to figure out how to identify these patients in clinical practice, we actually went through the literature. We kind of tried to figure out which questions might help identify people. And then we brought people in who had been recently diagnosed, as well as those who didn't have COPD. We kind of went through and used those questions to pick the best questions. And then we actually later validated that out in primary care. And what we came up with here's some of the questions that we came up with for trying to identify people. It's not just, do you smoke? It's other things like polluted air. We know that dusty, dirty jobs, occupational exposures are also important. Did people have breathing changes with either seasons, weather, or air quality? Did they have activity limitation? Do they tire easily? And then we had one question in here that was associated with an exacerbation-like event. When we combine that with peak expiratory flow, which is pretty easy to do in the office, that's kind of where we found the best results. I'm going to go back for a second. So where we kind of kind of found the best situation was, or for identifying people with COPD, was both a higher score as well as a low peak expiratory flow. Those were kind of the best combinations. And then we actually went out and we after developing it, we went out and actually tested it in thousands of primary care patients throughout the United States. And so this kind of goes through sort of what we were able to find and how good the various scoring criteria were for, and you have variations in the sensitivity and specificity depending on which threshold you pick. But I will say probably the thing that was most associated, to be honest with you, out of anything with airflow obstruction was actually the peak expiratory flow, which I think makes sense because it's kind of like, not exactly like, it's not a perfect surrogate for spirometry, but it's probably, one of the things that we did that was sort of the closest. One of the other things that we're doing here at the University of Michigan, which is sort of a future state event, is trying to figure out if we could actually use lung cancer screening CT scans to figure out who has COPD. It turns out that emphysema is associated with exacerbations, more symptoms, increased mortality. And so we're actually in the process of doing that right now here at the University of Michigan, trying to see, is there a best threshold for emphysema on a lung cancer screening CT scan where we could flag those patients as potentially having COPD. So I think that's a potential future state scenario for a totally different approach for trying to find these patients. It's kind of odd if you think about it that we're looking at something as advanced as CT scans, but the fact of the matter is that the CT scans are getting done now because of lung cancer screening, whereas spirometry, it's still a struggle. So the thought is, if we can use the lung cancer screening scans to identify patients that should go on and have spirometry, that might be another way to go. So I mentioned there's also a group of patients who do not fit the current diagnostic criteria, but maybe we should think about treating. This is not what GOLD looks like now. The way GOLD looks now is just the 1, 2, 3, 4. This GOLD 0 group they got rid of. And they got rid of it because it was a symptomatic group, but it wasn't clear that those patients necessarily went on to develop airflow obstruction. After they had the first iteration of the GOLD document, which, if anyone is curious or you're not familiar with GOLD, GOLD was actually started in around 2000. And it was a partnership uh, between the NIH. I'm trying to remember who all was involved. I wasn't actually there at the founding. Um, it was a partnership between the NIH. I think they had industry support, and I think it was also the World Health Organization. Since then, it's sort of its own entity now, and it updates the document once a year, but it brings together a group of international experts that tries to review all the evidence that had been published in last year and really provide the best information regarding diagnosis and treatment. It's freely available. And so if you're curious, you can just check out their website. I think it's goldcopd.org. But just type in gold COPD and you'll find it. I believe there's also an app if you want more information about that. So this was data that came out after that original iteration of GOLD, which was in 2000. And what they found was that certain symptoms were associated with future lung function decline, but that unfortunately the majority of people who progressed actually didn't have symptoms. And so they didn't really know what to do with that. They weren't sure whether this symptomatic, not obstructed group was meaningful. And so in the next iteration of the document, they just went ahead and dropped it. The problem with that, though, fast forward 20 years or so, the problem with that is that it sort of took this group of patients off of everyone's radar. And what we now know after about 20 more years of research, and there's been a couple of large NIH-sponsored cohort studies that have included symptoms and PFTs and CT scans, and this includes studies like the COPD gene study and spiromics, which are two large NIH-funded cohorts. What we found is that just because those patients don't have airflow obstruction doesn't mean they don't actually have disease. And this is where poses a real quandary for physicians, because we know they have exacerbation-like events, increased mucus hypersecretion, cough, shortness of breath. They had some real symptoms, but to be honest, it's been a challenge to try to figure out what to do with them. This is not a group of people that have been systematically included in clinical trials because they don't meet the GOLD definition for COPD. So they've been actively excluded from all of the clinical trials where things like long-acting muscarinic antagonists and long-acting beta agonists, inhaled steroids, which we all know benefit patients with COPD. These patients have all been excluded from those trials. So it's been a real challenge to know what to do with them. If we look at them as a group, about 20%, and this is data from COPD, about 20% have either emphysema or gas trapping. If you add airway wall thickening, about 40% have abnormalities. And roughly a quarter of those patients have a pretty significant dyspnea score on something called the MMRC, which is a dyspnea scale. They also, as I mentioned before, have exacerbation-like events, and not just exacerbation-like events, but ones that cause them to miss work, miss social activities. So they're clinically significant events. In the spiromic study, we did try to drill down on these patients a little bit further. And we used something called the COPD assessment test, or CAT score, to identify patients who had symptoms. Just in case you guys are curious, MMRC is free online, CAT's free online, but GOLD uses a CAT score of 10 or more or MMRC of 2 or more to define symptomatic. So in this particular analysis, they split patients into high and low CAT, and then they also split patients into airflow obstruction or not. So the patients have airflow obstruction on the right-hand side and no airflow obstructions on the left-hand side. And what they found was that actually the patients who had high CAT looked more similar regardless of whether they had airflow obstruction. And the patients who had low CAT looked again more similar regardless of the level of airflow obstruction. And these high symptom patients were having frequent exacerbation events. So we drilled down even further, and it turns out when we look at the CT scans, it's not emphysema That was more associated with airflow obstruction. What the symptoms were associated, though, was with airway wall thickness. And then we did even more analyses on sputum, and we found increased mucin concentrations in these patients who, as you get more severe COPD, more frequent exacerbations, more phlegm production, we saw more mucin. But in these gold zero patients who had symptoms, we again saw higher mucin scores. So it suggests there's real pathologic abnormality. What I don't have for you yet, though, is a specific treatment for these patients yet, other than aggressive targeted smoking cessation. We know smoking is associated with mucus hypersecretion. We know that the presence of chronic bronchitis can be picked up in smokers as early as their mid-30s, and that it's associated with more rapid lung function decline if they continue to smoke over time. So if you see a younger individual that already has got symptoms of chronic bronchitis and they're smoking, I mean, every patient needs to be counseled to stop smoking. But if they've developed symptoms in their, younger years, I think that to me is a flag, that even more of a flag that this is a patient probably should test, make sure they don't already have COPD, but also strongly counsel to stop smoking. So I told you we don't have any therapies for this group of people. We actually did one clinical trial on this group, and this was a study that I helped to lead. We did this at the University of Michigan, and what we tried to do was to treat them with the same medications that patients with COPD would get. And so in this case, we did a dual long-acting bronchodilator combination with a beta agonist, indacaterol, and a long-acting muscarinic antagonist, glycopyrrolate. So we went ahead and gave these patients this dual bronchodilator combination who had symptoms. Turns out, unfortunately, it didn't help. It just didn't help. And to me, this suggests that it's not so much small airway disease, which I would have expected this drug to help in these patients, as probably larger airway disease. And we probably need to focus on some kind of like mucus specific drug, which I'm hoping we can work on developing, but right now we don't have yet. One of the challenges that we face with COPD is we don't always know who's going to experience more rapid lung function decline. This is what I kind of was taught in medical school. This maybe is showing my age, but kind of this concept of the Fletcher-Peto curve, where everybody starts off with good lung function, and then if you are exposed to bad things, you have more rapid decline. What we now realize is that's probably not exactly what happens. What we now realize from this paper that was published by Peter Lenga back in 2015 from the New England Journal of Medicine is that it is a false assumption that everybody reaches adulthood with quote unquote healthy lungs. I mean, if you think about it, we track children, we track all sorts of things, right? We track weight, we track height, and we know some children fall off the curve. Well, just like some children fall off the growth curve, some lungs fall off the growth curve, but the challenge is we never measure it. We only measure lung function when people get really sick. And so the challenge is that most of the lung function testing we have both from cohort studies as well as in the office are patients in their 60s, late 50s and 60s. At that point, it's really hard to figure out what's going on. You have some people that probably had an issue in childhood and then have been relatively fine in adulthood, but there's probably not much you can do at that point, versus people that hit adulthood with good lungs and then are experiencing more rapid decline. And so it's probably these patients on the red line that if we're going to target anybody for therapy in adulthood, it probably should be those people. But the question is, how do we find the people in red? So one of the things that I've been working on has been trying to find younger patients and study younger patients so we can start figuring out when do we need to start doing spirometry, what are the risk factors, what does this early disease look like, how do we identify it, and then ultimately, how can we intervene? So when I talk about the term early COPD, it's not just sort of first signs of the disease in terms of mild stage, it's also younger. Because I think one of the challenges is historically we've been trying to study old patients with mild disease, but those are, if you think about it, probably super resilient people. If a patient has smoked for 40 years and is minimally symptomatic at 80, that's probably not the patient we need to be studying. We want to study the person that's got significant disease in their 30s. If we want to try to figure out how to help people in their 50s and 60s. So one of the questions is how do we kind of identify these people? There has been an operational definition for early COPD that's been put out there, and that includes either kind of some slight abnormalities in lung function, or CT, or accelerated lung function decline. Challenge is this has been a bit difficult to operationalize um, because a lot of times we aren't doing any of this routine testing in primary care. So in fact, while I'm not going to be getting into more detail about this today, I'm headed to the American Thoracic Society meeting this week. Gold will be meeting on Friday. And one of the proposals I actually have on the table, and I'm hoping it'll be a paper that comes out this year, is actually a proposal that we should start getting spirometry routinely younger. Because if we don't, it's very difficult to actually interpret what's going on with a patient later. You don't know if they're really having accelerated decline or whether low lung function later is actually perhaps a reflection of something that happened much, much earlier in life. And so we'll see how that impacts things, but we're going to kind of put out this proposal document for universal earlier spirometry. One of the things that we did do, though, with gold is we've kind of replaced this concept of gold zero with pre-COPD. And whereas gold zero was this idea of milder disease with symptoms that are, before airflow obstruction was established, we've broadened this to kind of say, okay, well, it could be symptoms, it could be CT abnormality, it could be some other subtle physiologic abnormality. But all of these things potentially could be used to identify a patient that's at risk for ultimately developing airflow obstruction. So that's where this idea of pre-COPD comes in, whereas early COPD is kind of the same thing, but just, where we've added that caveat of younger. So one of the things that I had mentioned earlier is that we can start to see this sort of accelerated decline in lung function with exposures, really, I would say in kind of the late 30s, early 40s. And so unfortunately, this is again way before many of the patients are picked up. When we begin looking at these patients using a very specialized technique called micro CT scanning, one of the things that we found is that they actually start to lose the small airways at a very early stage. And we think that sort of is the precursor for emphysema development. Probably the first paper that looked at this, or most famous paper, was by a pathologist named Jim Hogg in Vancouver. And here, mean linear intercept just means like alveolar size on the lungs. And what they found was that the patients who had emphysema already were dropping airways even before they developed emphysema, as you're measuring alveolar size. Sorry, I misspoke. So that's kind of some of the evidence that we have. One of the kind of more fun projects that I've been involved with at the University of Michigan has been to develop a way of trying to identify that small airway disease early before the development of emphysema. So when we look on a CAT scan, that can be super hard to detect. But what we figured out here at the University of Michigan is that, so you guys see on this scan here, when you go from inspiration to expiration on the CAT scan, you see how it goes from black to gray? That's normal. The lungs should get more dense as it expels air. If air is trapped, it stays black. And so if we find areas that have no emphysema but trap air, that's how we can distinguish small airway abnormalities. So we have this way of mapping these colors onto the lung to identify healthy tissue in gray, small airway disease in yellow, and emphysema in red. And we've been able to then kind of group patients based on how much yellow they have, that's what we call PRM-FSAD. It stands for parametric response mapping, which is the technique, and functional small airways disease is what FSAD stands for. But the bottom line is that if the more yellow we find, that's high group with the most amount of yellow, and these are patients who still have quote unquote normal lung function, are at greatest risk for decline. So this is a tool that we're starting to use to identify these at-risk patients. And this just shows you some CT scans that we did here at the University of Michigan where over time you can see the areas of yellow become red. So that's the small airway disease turning over into emphysema. we now actually have this software installed at the University of Michigan. And so every patient who has COPD or suspected COPD, we can, check a box, and when we order it, and we get these color images so that I can use this for planning purposes. We actually incidentally also use this when we're trying to decide which patients might qualify for valves, which is a therapy that we can use for severe emphysema, but it really only works for patients who have emphysema and not small airway disease, which you can't always tell from a breathing test. And so for valves, we're looking for the red, and we don't want as much yellow. So that is another place where we're routinely using this imaging technique. One of the fun things that we did actually here at the University of Michigan was to validate this yellow, green, red technique for identifying tissues. We actually took lungs out at the time of patients getting transplant. We inflated them, we froze them, we cored them. We actually sent them to that pathologist I just mentioned in Vancouver, Dr. Hogg, and we analyzed these what we call micro CT scans. Just look at the very small here. You can see the tiny airways and the tiny air sacs to see if it correlated with what we were labeling as emphysema and small airways on the CT scan. And it turns out that it's pretty accurate. This is just this is what it looked like, because I'm not very good, I'll admit. That our surgeon and nursing team are here, but since I don't have, a lot of times I was left to my own devices when we were doing this study. It wasn't a pretty suture job. I had to use zip ties to get the lungs inflated. But as you can see, this is a tiny microscope version of those airways. And you can see in the patient that had COPD, we start to see narrowing and fibrosis, and ultimately loss of those airways, compared to a healthy lung where the airways are nice and open and thin. And so this just kind of helps to, again, for kind of further validate that technique. And then I'm just not even going to get into this, but this is just all the statistically significant things we found that just showed that the microscope version matches with the color coding on the CT scans that we were doing with patients before surgery. So we also know that these patients that have a lot of the yellow on the CT scans, the small airways, these also have increased mucin as well. And I kind of mentioned that earlier. So that's something else that I think it would be really nice. And we actually, believe it or not, I mentioned this earlier. There's 2 new therapies that were approved for COPD this year. Maybe this is a good place for me to slip this in. One is called ensifentrine, and it is a nebulized therapy. And the data would suggest it probably is most beneficial for helping with shortness of breath. It actually, interestingly, did show some exacerbation reduction benefit, but the studies were not designed in patients that were on maximal inhaled therapy. So these patients were not all on what we call triple therapy with inhaled steroids, long-acting beta agonists, and long-acting muscarinic antagonists, which is what you would max patients out on if you thought that they were at risk for exacerbations. So we don't really know what to do. At Gold, we weren't sure what to do with the ensifentrine data. But if you have a patient and they are on triple therapy and they're still having shortness of breath, ensifentrine is something you can try. But the reason I was actually thinking about the new therapies for COPD, and I apologize, I don't have a slide on it today, is that dupilumab, which is the other medication that was approved for COPD, actually does help to target mucus. And that drug targets the IL-4, IL-13 pathway. Many of you are probably familiar with dupilumab because it's also approved for asthma. But it turns out in COPD, it's most beneficial for patients who have an eosinophil count of 300 or more. So it's a subset, those who have frequent exacerbations, high eosinophil counts. But I just thought I would mention it because it kind of ties with this mucin theme that we've been talking about today, and is beneficial for a subset of patients. So ultimately, as we kind of move forward and start thinking about ultimate new treatment development, targeting earlier patients is going to be really important. Because one of the things that we have found, most of the patients that you and I probably see in clinic are probably, in this maybe late gold 2 to gold 3 to even gold 4 range. But look where patients are losing lung function the fastest. It's up here in the gold 1. And in fact, gold 1 is such a fleeting state that it's really actually hard to capture patients during gold 1. We've done a bunch of cross-sectional studies now, and even in younger patients, and we'll have patients like just very briefly blip in and blip out of gold 1 before there's suddenly something else. So it's actually really challenging to find somebody who is still gold 1 because they're getting worse the fastest and they spend the least amount of time in that gold 1 stage. What we don't know, but would be sort of the ultimate holy grail question, but I don't have tons of data on it. I'm going to show you the data we do have, is how disease modifying would it be to even just start appropriate inhaled therapies for these patients early on? The limited data we do have is this study that was published in the New England Journal of Medicine back in 2017, where they just used tiotropium, which is a standard medication, long-acting muscarinic antagonist that we use for COPD. And they gave it to patients who had gold 1 and 2 disease. And what they found was that there was a preservation in lung function over the short course of this 2-year study. So there is some evidence that starting earlier with even inhaled therapies may make a difference in where patients ultimately end up. But again, this is even this feels kind of short with just 2 years worth of data. So one of the things that we're also doing at the University of Michigan right now, we just completed enrollment and we're starting to follow these patients, is we did recruit some really young patients, kind of 35 to 50, with either mild airflow obstruction, some mild restriction, or no airflow abnormalities at all. And we're going to be following patients over time, assuming the NIH doesn't cut our funding, which is an ongoing challenge in the current environment. So, I think what I hope that you take away from this, because I know this talk is a little bit more theoretical and maybe a little bit less practical, is that one, we really need to be vigilant for identifying patients with COPD earlier. Think about doing spirometry earlier. And even if the patient doesn't have abnormal spirometry, if they've got symptoms or if they still got risk factors, you want to think about repeating that over time. Once they do develop airflow obstruction, good evidence for long-acting muscarinic antagonists and long-acting beta agonists together in combination. That's really kind of first-line therapy for patients who develop symptoms with their COPD. Once they develop frequent exacerbations, that's where GOLD recommends adding the inhaled steroids. And then, like I mentioned, just in the last year, we have some kind of additional add-ons, including ensifentrine and dupilumab. The good news is that there, I think, hopefully, going to be some more interventional studies in this early COPD group, so we'll know how to better treat them in the future. In addition, there are a lot of other drugs that are other biologics in particular, targeting other pathways, not just eosinophilic COPD like dupilumab, but there's the next, I think, clinical trials we expect to read out are on drugs that target another cytokine called IL-33. And so that'll be a kind of a broader COPD patient population, not just a high eosinophil patient population. And so, we're kind of very excited about potentially a whole new slew of treatments that could be available for COPD in the next few years. So I realize I kind of went fast with that. But I'd really be happy to open it up for questions and address much more practical things if people want me to go through more on my approach to diagnosis, my approach to first-line treatment, my approach to what to do if people are exacerbating, approach to how to how we evaluate people for valves or COPD. Again, happy to talk about anything people would like. Or if there's no questions, that's okay too, and people can enjoy their lunch.
I have a question. I was wondering how you manage dealing with kind of insurance constraints when we're looking at trying to diagnose something a little bit early or where patients may not be real symptomatic. I find that to probably be one of my bigger challenges in practice is just insurance barriers, coverage, patients out-of-pocket costs, that sort of thing.
So are you talking about for spirometry or medications? Which one?
Sorry, more for like spirometry or screening in that regard, like you said, trying to get ahead of these patients that are earlier in this process.
So I have to admit, I have not had much in the way of problems, but maybe it has to do with coding. I wouldn't code it as screening. I would, typically put something like concern for COPD based on shortness of breath or activity limitation, or I would associate it with some kind of a, even if or even just put COPD because you don't know but you suspect it based on history. When, at least in my experience, when I've coded based on that and not put screening, I haven't had issues. But have you had issues even with that?
I wouldn't say that specifically. I think more of the concern might come from the patient perspective of like how much they may need to pay or and kind of like getting them to feel invested that, hey, in doing this test, we might identify something early that we can treat, that kind of thing.
Yeah. I guess I can just, and it maybe I get a slightly different patient population in my office. Every once in a while, we'll have a spirometry rejected, but usually, to be honest, when we have it rejected, it's because they've had like 20 tests in a year because I ordered one and their PCP ordered one and the local, you know what I mean? But just the one, just like getting one with a strong, like, smoker suspects COPD or, shortness of breath, whatever, it's not been common to get those rejected. So I guess I would just say, first of all, it's uncommon to get those rejected. Um, and then, um, I would say also just that it's important to establish a baseline, because if they get sicker later, it's really hard to, know where they started. One of the things I will tell you that I have started to do in my practice is I actually take a birth history as well. So I will ask if people were born premature. I will ask if they ever had respiratory problems as a child. Did they get frequent infections? Did they have a history of asthma growing up? Because all of those things will put you at increased risk for lower lung function into adulthood. And so the more, history that people have, the higher the likelihood that you're going to pick something up. So that I think that, you can depend, that may not apply to every patient, but that's something else that you can, weigh in also, like high risk jobs. You want to establish, I mean, think about, all the places where you want to establish a baseline to see if, whatever it is, frequent exposure to secondhand smoke, dusty, dirty job, et cetera. Depending on where they work could influence things. So I think well, that isn't going to help you in every single case. That's some additional ammunition you can use to help people understand why it's important, if that helps. Okay, I'm going to look at the next question. What is the percentage of patients in your practice who have a diagnosis of COPD but were never smokers? Okay, that's another really good question. If you look at the data nationally, I've never calculated it for my personal practice, but the data nationally is about 20%. So, and again, this is it's actually more common in women who've had a history of asthma. So some of these are people who, it may be that asthma turned into fixed airflow obstruction. But again, this is the people who had secondhand smoke exposure growing up, or respiratory infections growing up, um, or some other exposure. Sometimes I never quite figure it out, to be honest with you. But yeah, just because somebody hasn't smoked doesn't mean that they're, risk free. And if you'll notice on that capture questionnaire, everybody, the question wasn't, have you ever smoked? It was, have you ever been exposed to? And there was a list of things. It was not just personal smoking, but secondhand smoking and, occupational smoke. The other thing I will mention, is that I don't know what to do with yet is all of these young people that are smoking marijuana and vaping. Um, what I can tell you is we're doing another study that I didn't show today called the Lung Health Cohort Study, which is a joint project between the American Lung Association and the National Institutes of Health. And we're bringing in 25 to 35-year-old community dwelling individuals, not necessarily people who smoke or vape, and just bringing them in. And what I'm finding is a lot of patients with inflammation on the CT scan that I, in any other circumstance, would have thought would be related to smoking and patterns I've seen with smoking. And so I've been calling these people saying, I'm concerned about, these findings. Are you smoking? What's going on? And I am finding marijuana and vaping. So I don't know what those patients are, if they continue to do this, are going to look like in 5 or 10 years. But the early findings look very similar to the same damage I'm seeing with tobacco smoke. So that is something else that is another, in my mind, risk factor group. We still need more long-term data on what happens with that, but there's clear, to me, early evidence of lung inflammation with both of those exposures. Okay. Anybody want me to go through anything more on my rubric for treatment or approach to anything else like that? I wish I had some slides on it, and I apologize I didn't. But if you have any questions, like I said, you can all go to there's a small like pocket guide as well as the more full like 600-page document on the Gold website. Okay. Well, sounds like that may be it for today.